We always talk about family history, but family history that my dad had an MI at 85, I'm not quite sure what that means. And usually, I would tell you it probably doesn't mean much. But family history of coronary disease at an early age is clearly a big risk factor. So if a 45-year-old comes in with very atypical chest pain, but tells me that their two uncles and their aunt and their dad had MIs, not just heart, we always say, did they have heart disease? We have to be specific about what we mean by that. Had MIs at an early age, I'm very worried about this patient. Peripheral vascular disease, that makes sense, right? Coronary artery disease is a vascular disease. So people who have claudication, who have peripheral vascular disease, who you see a scar for aortic bypass, these are clearly patients that are at risk. Chronic kidney disease as well. HIV, once again, likely due to maybe the inflammatory processes, especially if they're on protease inhibitors. And not just obesity, but the ones that we've been looking at, or that's been looked at, is the waist to hip ratio. These are the ones that are, so somebody could be coming in who is a very athletic person that might have a very high BMI, but the waist to hip ratio is really what makes it or breaks it. You don't need to see all of this, actually none of this. This is just classic data of the utility or lack of utility of our classic questions that we ask about symptomology, as well as where's the chest pain, does it radiate, does it not radiate? And you could see the positive likelihood ratio is the highest is 4.7. So that's for radiation to right arm or shoulder. So 4.7 is fine, but we start getting excited about positive likelihood ratios if they're approaching 10. So it's not very good. And the negative likelihood ratios for things like described as pleuritic or positional, things that we think are very atypical, also don't decrease the likelihood of disease that much, 0.2. So they're not very good. So atypical is typical. So 1/3 of patients will have no chest pain, especially the elderly, the women, the perimenopausal women, and of course diabetics. We have to be careful about equivalence, so shortness of breath with no chest pain. So it's sudden onset of shortness of breath, sudden onset of diaphoresis, so on and so forth. And we have to also remember, like I said, we showed you those negative likelihood ratios, is that pleuritic chest pain and reproduced on chest wall palpation, the things that we would think of are not that worrisome. 10% of patients with true ACSs have these. So then where are we left with? Well, we're left with our clinical decision toolbox. And there are a few things that can help us out, from the heart score to TIMI, so on and so forth, that if you have trouble with your clinical gestalt, you can always rely on and go back to these scores to help you out. So we talked about definitions, we talked about history, the utility or lack thereof. Let's talk about ECGs, and then clearly I'm not in the same context as Amal Matou, but let's just talk about a few things that I find are important. Once again, the numbers are very low, but just to show you that we're not that good at interpreting ECGs. This is a fairly recent study looking at negative predictive values for ECGs in the context of ACS. Emergency physicians or even emergency specialist attendings, you're looking at 60%. Not that good. Mind you, our cardiology colleagues are also along the same space. So we have to be careful in how we interpret these ECG findings, because clearly we're not doing the best. Just a couple of things that I want to call your attention on is non-specific changes is not equal to normal. So if a patient comes in with chest pain and they have non-specific STT wave changes, do not say that as normal. In fact, some people would say that would be an indication to do a 15 lead. Remember the left bundle branch or pace pattern, and we clearly have, which I'm not going to go through, but we have sort of clinical guidelines to show us when that LBB is important and when, what are the criteria to be worried about. Be very careful with patients, this is more and more known, patients with acute chest pain that's very significant with a new right bundle and left anterior fascicular block. Very likely a proximal LAD lesion. We also know that ST segment elevation in AVR with some ST segment depressions, other places can be a hallmark of left main coronary artery disease. So those are the ECG findings that we have to talk about. The exam, I'll be very brief. It's really to rule out, quote unquote, other things. And we can go through the signs and symptoms of other chest pain syndromes, but as much as say, I think we need to use the ultrasound. I think our clinical skills are not very good to pick up these things, and as a way of differentiating the problems that can present as chest pain, ultrasound is of note. Let's go quickly about tropes and markers. There are definitely new kids on the block that are helpful. So just so you know out there, you don't have to know, because we're not using any of these as is. But more and more, we're seeing that these new markers are just as good, maybe even better than our tropes. And that previous paper highlights the fact that this particular marker can be just as good and even at an earlier stage than your tropes. So the last word on markers and tropes is that CKMB is gone. I think we all know that. You really need 2 sets of tropes unless the patient has had more than 6 to 8 hours of chest pain, or their symptoms are clearly longer than that. I don't think it makes sense to do more than that. But if they're within that 6 hours, you definitely need to. And then this thing that we sometimes blow off is any leak, trope leak, should mandate a second one to see for trends. There is a more and more literature out there about the fast and furious or a quick rule out. Using basically these are the studies that highlighted this, and it's really, if you have a high sensitivity trope that is within normal, that is negative with a normal ECG and low score in a risk stratification tool, then you're pretty good to go with a very high negative predictive value. So that clearly, that's a trend that's coming, and that we're starting to see. In the end, more and more of emergency medicine is about shared decision making. The Mayo Clinic uses this often, and actually this study came out of the Mayo Clinic looking at using this tool to show patients what their likelihood of disease could be. And it shows in graphical terms that if you have, they ask you your chest pain, your diagnosis, further test, and basically you put together a risk stratification tool, and at the end it comes out with a tangible number that a patient could understand and say, listen, these are my risks, and I choose not to undertake further risk stratification. And the study showed that the patients felt more sort of a greater knowledge, less decisional conflict, and decided less frequently to be admitted to be worked up. So shared decision making is clearly in its way. If the patient is not hypoxic, we don't need nitroglycerin. We know it does not impact morbidity and mortality. It's really for symptom control and hemodynamic control if you need it, as far as high BP. Not magnesium, but morphine sulfate. There's some evidence that it might impede absorbance of your antiplatelet agents, so there might be an issue with giving that. Beta blockers, PRO-IV, and a statin. That's your appetizers. Now we dichotomize, or we try to dichotomize between STEMI and NSTEMI, or the so-called ACSs. So once again, here too, we use risk stratification. And if the NSTEMI, I'm going to call it NSTEMI, is very high, VH means very high risk, and the very high risk is defined as a patient comes in with an NSTEMI with electrical or hemodynamic instability, or any of these bad ECG signs such as Wellens. We talked about the right bundle with the left anterior fascicular, De Winter's STT waves, ST elevation AVR, the ones that I mentioned. So they don't have true definitions of a STEMI, but they have these risks, then they should be treated as a STEMI. Also, you can use the GRACE score, more than 140, also puts you at a very high risk in the context of an NSTEMI to be treated like a STEMI. We risk stratify dual antiplatelet agents, so aspirin and one of the below ones. We anticoagulate, and then the algorithm sets off on its own. I don't think we need to go through this, but just so you know that there is a classic algorithm for treating these. Rip perfusion, very briefly. The indications we all know very well. There's nothing really new about those. The choice of perfusion strategies. Once again, I think the only thing of note is the ones that are not NSTEMIs but have very high risk should be treated like this. Cabbage is less and less used, and then the facilitated PCIs in the context of somebody who can get to a cath lab fast enough. Very briefly, out of out-of-hospital arrests, cardiac arrests. So you have an out-of-hospital cardiac arrest. You definitely you make do. You get your ECG quickly, and then you risk stratify based on the patient's clinical scenario, and you can actually PCI these patients as well. ECMO, clearly there's evidence for it. This is a fairly recent paper showing that there's more and more utility in using ECMO. And my last slide is the following, and I think we need to be superior doctors. So this is an old Chinese proverb: superior doctors prevent disease, mediocre doctors treat the disease before it's evident, and inferior doctors treat the full-blown disease. And I think we need to try to be the superior ones, not the inferior ones. Thank you very much.